So I want you to take a deep breath in, just, a normal deep breath, and hold it for a second.
Right.
Because right now, as your lungs are completely full of air, a hammock of 14 separate muscles at the base of your pelvis just dropped 3 full centimeters just to make room.
Yep, a full 3 centimeters.
And then as you exhale, that entire muscular shelf is going to rise right back up. I mean, you probably don't feel it, but there is this massive invisible piston constantly moving inside you, just accommodating every single breath you take.
It's incredible. And, if that piston stops moving optimally, or if the intricate alignment of that hammock gets thrown off by even like a few degrees, the entire system can just start to malfunction.
Right.
And in ways that impact almost every single aspect of your daily life.
Which really brings us to the mission for today's deep dive. Because you, the listener, handed us this incredibly dense, truly staggering stack of material.
Oh, yeah, it was a lot.
You sent us anatomical textbooks, urology and gynecology journals, PT guides, clinical protocols, and we've basically gone through all of it to extract the ultimate aha moments, really to answer one specific, fascinating question.
And it's such a good question.
It is. Can pelvic anatomy actually explain why symptoms, things like pain, urinary incontinence, or prolapse, why they vary so drastically just by changing our physical position?
Right. And it's a brilliant question because to even begin to answer it, we have to completely dismantle how most people view the pelvis.
Yeah.
Because I think the standard, layperson understanding is to treat the pelvic floor like this static porcelain bowl.
Right, exactly, like a rigid basin.
Exactly, just sitting there, completely unmoving. But the literature you provided paints a radically different picture. The pelvic floor is actually this highly dynamic, load-bearing suspension system.
A suspension system.
Yeah. And today we are going to explore how invisible forces, so gravity, spinal posture, skeletal angles, how they act as levers that quite literally control our internal plumbing and our comfort.
Yeah. So before we can understand why changing positions changes those symptoms, I think we really need to understand the baseline machinery here.
For sure.
Because when I was looking at, I think it was page 40 of the medical journal you sent us, I literally had to stop and reread the structural breakdown.
Quite complex.
It really is. I always pictured the pelvic floor as like a single flat sheet of tissue, like a drum head stretched across the bottom of the pelvis. But that is incredibly inaccurate.
Yeah, far from a single sheet. It is a complex musculoskeletal sling made of 14 distinct muscles.
14.
14.
Yeah.
And they aren't just, thrown in there. They are arranged in 3 highly specific layers, spanning all the way from the pubic bone in the front to the tailbone, those coccyx in the back.
And it has to manage 4 distinct compartments of the body simultaneously, right?
Yeah.
Like you have the anterior compartment, which is dealing with the urinary system, so the bladder and urethra. Then the middle, the genital compartment containing the vagina and uterus, or the prostate. The posterior compartment for the bowel and rectum. And finally, the peritoneal compartment, which is this whole intricate web of connective tissues, ligaments, and fascia that are just holding all of those organs in their proper place.
And what's fascinating here is the evolutionary context behind why this area is so intensely complex.
Oh, the bipedalism stuff.
Yes, humans made this profound evolutionary shift to bipedalism, right? We stood up and started walking on 2 legs.
Right.
And when we did that, we completely rewrote the structural engineering of our bodies. If you look at a 4-legged animal, like a dog or a horse, their heavy internal organs are primarily supported by the thick horizontal wall of their abdominal muscles.
Because gravity is just pulling down on their belly.
Exactly. But for us, standing vertically on 2 legs, gravity pulls all of those organs straight down toward the pelvis.
Wow.
Suddenly, this 14-muscle trampoline at the bottom of the pelvis is forced to constantly fight gravity just to keep our organs inside our bodies.
That just sounds exhausting. It's literally working against the weight of our own biology every single second we are upright. How do those muscles not just fatigue and totally give out by noon every day?
Well, that comes down to the cellular makeup of the muscles themselves. The sources detail how the pelvic floor basically acts as a constant valve mechanism.
Okay.
And to do this, it's composed of roughly 70% slow-twitch type 1 muscle fibers.
Meaning what, exactly? Are we talking about a marathon runner compared to a sprinter?
Precisely. Fast-twitch fibers, the type 2 ones, are your sprinters. They give you that explosive power for lifting heavy things, but they fatigue really quickly.
Right, they gas out.
Exactly.
Hmm.
Slow twitch fibers, though, they're your marathon runners. They rely on sustained oxygen and cellular respiration to maintain this low-level constant resting tone without fatiguing.
So they're just always on.
Always on, working around the clock, contracting just enough to keep the urethra and the rectum closed against that constant downward pull of gravity.
Mm-hmm.
But you also have that 30% fast twitch fiber makeup in the pelvic floor.
Right, for emergencies.
Yeah, they're there to suddenly clamp down when you cough or sneeze just to prevent sudden leakage.
Okay, let's unpack this. Because if the pelvic floor is like a trampoline full of marathon running muscles that are constantly fighting gravity,
Mm-hmm.
what actually happens when we stand on that trampoline for 12, 14 hours straight?
Yeah, that's the big question.
Because even marathon runners hit a wall, right? And this perfectly explains a massive revelation in the research you provided, which is the time of day effect.
Yeah, gravity's toll is undeniable here, and we see it most clearly in a condition called pelvic organ prolapse, or POP.
Right.
This occurs when that structural support we talked about fails, and organs like the bladder, uterus, or rectum literally begin to descend or bulge into the vaginal canal.
And the epidemiological data in your sources shows this affects up to 50% of people who have had a vaginal delivery.
It's incredibly common.
50%. And a defining clinical hallmark of this condition is that the symptoms, a severe feeling of heaviness, bulging, or like a dragging sensation in the pelvis, they often worsen significantly as the clock ticks from morning to evening.
Yep, and reading through the biomechanics section, it's all about the anatomy of position. It is sheer physics.
Sheer physics.
When you are standing straight up, your vaginal axis becomes much more vertical. You're basically taking the full weight of those internal organs and putting direct gravitational shear pressure right onto the urogenital hiatus.
And that's the natural opening in these muscles where the urethra and vagina exit the body, right?
Exactly. So when you're standing, gravity is pulling your internal organs straight down a vertical tube toward an open doorway.
Wow. But then the moment you change position and lie down horizontally, the internal geometry completely shifts.
Entirely. The axis of the mid-vagina to the apex becomes much more horizontal. Instead of a vertical drop, the anatomy creates an angle of about 120 degrees.
Okay, wait, I want to make sure I'm visualizing this correctly. By moving to a 120-degree angle, you're essentially changing it from a sheer drop-off into more of a gentle slide that points toward the back of the pelvis.
That's a really great way to picture it, actually. And that angle changes everything about how the body handles pressure.
Because of the direction of the force.
Right, in that horizontal position. If your internal abdominal pressure suddenly increases, say you cough or you laugh really hard, instead of pushing those heavy organs straight down and out of the body, that horizontal 120-degree angle directs the pressure backward.
Oh, wow.
It pushes the vaginal tube safely into the hollow of the sacrum, which is that large triangular bone at the base of the spine.
So the bone catches it.
Yes.
It hits a bony backstop instead of pushing against the soft tissue of the pelvic floor muscles.
Exactly. The sacrum takes the load. And this is exactly why the physical therapy texts you provided highly recommend a very specific, simple positional change for immediate symptom relief.
The wedge pillow thing.
Right. By lying on your back and elevating your hips on a wedge or a couple of pillows, you're actively utilizing gravity. You basically allow those descended organs to slide back up and reset slightly higher in the pelvic cavity.
Unloading the pressure.
Completely. It unloads the pressure from the muscles and ligaments, easing the discomfort almost instantly.
Wait, I have a practical question about this because this seems like a massive flaw in how we diagnose things.
Uh-oh, lay it on me.
If the presentation of the anatomy changes that drastically purely based on gravity and position, what happens when someone goes to the doctor for an evaluation?
Oh, I see where you're going with this.
Right, because if you schedule your physical exam for 8 in the morning, right after you've been lying horizontally in bed for 8 hours, isn't it entirely possible the doctor completely misses the severity of your prolapse compared to if you went in at 5 in the evening after standing on your feet all day?
Oh, based on the clinical literature, that is a known, heavily documented phenomenon.
That is wild.
The physical presentation of the prolapse, the actual degree of descent, is totally dynamic. It changes based on the time of day and how long you've been fighting gravity. It also changes based on whether your bladder or bowels are full, which adds literal weight to the organs.
And the sources even mentioned it changes based on your menstrual cycle, which I'll be honest, I didn't quite grasp the mechanics behind that one. How do hormones change the structural position of an organ?
Well, it comes down to tissue laxity.
Okay.
During certain phases of the menstrual cycle, specifically when your progesterone and relaxin levels fluctuate, the actual chemical makeup of your collagen and connective tissues changes. Yeah, the tissues become physically stretchier or more lax, so a ligament that feels firm and supportive on day 5 of a cycle might be much more elastic and prone to stretching under gravity on day 24.
That is just wild. You could literally be told by a medical professional, oh, it's not that bad, simply because you booked a morning appointment on a certain week of the month.
And this is exactly why the authors of these texts stress how crucial it is to understand these mechanics for self-advocacy.
Yes.
Your symptoms aren't fixed. They are dynamically responding to load, angle, and internal chemistry.
But the sources also make it clear that gravity pulling from below is really only half the battle here.
True.
There is a second, equally destructive force, and it's coming from inside the house, so to speak.
Pressure cooker.
Exactly. We are pushing our own organs down through the pressure we create in our abdomen, which brings us to how we sit, how we stand, and how we breathe.
Yes, the clinical term here is intra-abdominal pressure, or IAP.
IAP, right.
If you think about your core, it functions a lot like a sealed hydraulic press. The top of the press is your respiratory diaphragm, the bottom is your pelvic floor, and the sides are wrapped by your deep abdominal muscles, specifically the transverse abdominis, or the TRA.
And these muscles act as like a functional team to manage the pressure inside that cylinder.
Exactly.
And the texts are incredibly emphatic that our daily posture completely dictates whether that team can actually function. They specifically call out slumped sitting.
Oh, the absolute worst.
Which, let's be honest, is exactly how most of us sit at a computer desk, driving our cars, or relaxing on the couch.
Right, and when you slump, you compress the middle of that hydraulic cylinder. You drastically decrease the natural activity of the pelvic floor muscles, and you prevent the diaphragm from dropping properly when you inhale.
So the best analogy I could think of while reading this was a tube of toothpaste.
Oh, I like that.
Yeah, your abdomen is the tube. If you squeeze it aggressively in the middle, which is what happens when you slump forward and compress your ribs into your belly, and the bottom cap of the tube is loose, the toothpaste is going to leak out the bottom.
That is a perfect visualization.
And the PT sources point out a huge societal habit that makes this even worse, which is sucking in our stomachs.
Yes.
People constantly suck in their belly for a flatter appearance.
And from a biomechanical standpoint, chronically sucking in the stomach is disastrous. It completely ruins the natural breathing dynamic we talked about at the very beginning of this deep dive.
Because the piston can't move.
Exactly. If your stomach is rigidly pulled in, your diaphragm cannot physically drop down to pull air into the lungs. Your core loses all its flexibility. The pelvic floor becomes stiff to compensate, and a stiff muscle is a weak, inefficient muscle.
The texts also heavily focused on pelvic tilt. It's not just about slumping. It's about the literal angle of the bones themselves, right? Like an anterior pelvic tilt. Think of a swayback posture where your chest is puffed up and your tailbone is sticking way out behind you. That tips the pelvic bowl forward.
Right, pouring out the front.
And that increases the downward pressure of the organs right onto the front of the pelvic floor, specifically the bladder.
Conversely, if you look at a posterior pelvic tilt, so that's where you tuck your tailbone way under and flatten out your lower back, that alters the muscle tension in the completely opposite direction.
Right.
The muscles are constantly held in a shortened, non-optimal state, which prevents them from generating enough force when you actually need them to.
Which explains those really fascinating electromyography studies in the stack you provided.
Oh, those were eye-opening.
They attached sensors to measure the electrical activity of these muscles in athletes, and they found that the peak contraction power of the pelvic floor is significantly lower in athletes who have an excessive swayback or a completely flattened lower back compared to athletes with a neutral spine.
Yeah, it basically proves that raw muscle strength isn't the most important factor here.
It's the mechanics.
Exactly. During high-impact activities like running, jumping, or even just coughing, the timing of the muscle contraction matters way more than the power.
Right.
If you jump, your pelvic floor must contract a split second before your abdominal muscles brace. It has to secure the bottom cap of the toothpaste tube before the sides squeeze.
That makes total sense.
If the transversus abdominis fires first, it spikes the internal pressure. And if the pelvic floor fires even a millisecond too late, it provokes urine leakage.
Wow.
And if we connect this to the bigger picture, The implication is staggering. I mean, our modern sedentary lifestyles are artificially creating these severe pelvic tilts and muscular imbalances.
Just by how we sit.
Yeah. We sit at desks, we slouch, we restrict our breathing for aesthetics, and we misalign our pelvis. We are effectively turning off our core's natural shock absorption system. And then we wonder why the system completely fails us when we try to go for a run on the weekend.
Right, we're asking a complex anatomical design to execute commands while fundamentally out of alignment. Okay, so we've established exactly how posture and gravitational angles affect things like leaking and prolapse during the day. But here's where it gets really interesting.
Yay.
How do these exact same anatomical concepts translate to intimacy?
Ah, yes. It is a profound connection, and frankly, it's one that the medical community often overlooks. The journals make it really clear that pelvic floor disorders, whether it's prolapse, interstitial cystitis, or overactive hypertonic muscles, they are major contributors to sexual dysfunction and pain.
And it makes perfect mechanical sense. If the muscles are in spasm or the internal organs have physically descended due to gravity, penetration is going to cause direct mechanical conflict.
Just physically running into things.
Right. The sources noted that certain sexual positions directly exacerbate this anatomical pain. For example, if someone is in the traditional missionary position with a posterior pelvic tilt, meaning their lower back is flat against the bed and the tailbone is tucked up, it can force the uterus into an angle that is physically painful when contacted.
Or it can painfully jostle the bladder,
Yeah.
which is incredibly agonizing for someone with a condition like bladder pain syndrome.
But the beauty of understanding this through the lens of anatomy and position is that it strips away the stigma.
It really does.
It moves the problem completely out of the realm of, like, psychological failure and places it firmly in the realm of physics. And physics can be adjusted.
Yes. The positional fixes detailed in the clinical guides are brilliant in their sheer simplicity.
Just pillows, basically.
Right. For instance, just placing a wedge or a couple of pillows underneath the pelvis during intercourse immediately utilizes gravity to reposition the bladder and the uterus higher up in the pelvic cavity.
Oh, no.
It literally changes the internal geometry and the angle of penetration, relieving the sheer strain on those sensitive tissues.
The sources also highlight side-lying positions, right? Like spooning or positions where the individual experiencing the pain has complete control over the depth and the angle.
Exactly.
Because we mentioned earlier that a stiff muscle is a weak muscle.
Yes. And when a patient has hypertonic pelvic floor muscles, so meaning the type 1 fibers are just exhausted and stuck in a constant tight spasm, those muscles must be able to soften and relax to allow for comfortable intimacy.
Right.
By modifying the physical angle and reducing the downward gravitational pressure on the body, it actually allows the autonomic nervous system to feel safe enough to let those muscles stop guarding and finally relax.
I mean, that is just so empowering for the listener. It frames sexual discomfort not as some unsolvable medical mystery, but as an issue of levers, angles, and biomechanics.
Right.
If the angle hurts, you change the lever.
And that knowledge is transformative.
Yeah.
Knowing that a muscle spasm in the pelvic floor can refer pain to the lower back or the hips, knowing the breathing mechanics are directly tied to pelvic relaxation. It allows for highly targeted physical solutions.
It means people don't have to just suffer in silence.
No, not at all. They can consult a pelvic physical therapist to release those muscle trigger points, or they can simply use a wedge pillow to change the geometry of their pelvis in the bedroom.
So what does this all mean? We started this deep dive staring at a massive stack of medical literature you sent us, really just trying to figure out why symptoms change purely based on position.
Right.
And the ultimate takeaway is that your pelvic floor is this magnificent 14-muscle suspension bridge. And it relies entirely on how you manage the external force of gravity, the internal pressure of your breathing, and the physical angles of your skeleton.
It is a totally interactive network. It responds directly to the architectural loads we place upon it.
And I want to speak directly to you, the listener, right now. If you've ever noticed that your pelvic pain, your urinary urgency, or your prolapse symptoms are practically non-existent when you wake up, but they are unbearable by dinner time.
Yeah.
Or if you've noticed that certain office chairs make your lower back and pelvis ache while others don't, or if certain positions during intimacy are inexplicably painful, it is not in your head.
Definitely not.
It is literal biomechanics at work. Your symptoms are not random. They are giving you real-time data about pressure and angles.
Which really leaves us with a totally new, rather provocative thought to consider moving forward.
Okay, let's hear it.
Well, if gravity and skeletal angle are the absolute masters of pelvic health, It makes you wonder about the long-term compounding effects of things we consider totally normal in our society-like fashion.
Fashion? Wait, what do you mean?
Think about high heels,
Oh.
right? If wearing a heel fundamentally raises the back of the foot, it forces the entire pelvis into a severe artificial anterior tilt just to keep the body upright.
Oh my gosh, you're right.
So if angle dictates muscle function, are we artificially creating the exact geometry that guarantees a weak, inefficient pelvic floor simply through the shoes we wear every single day?
Wow, that is a fascinating point to end on. You fix the shoe, you change the angle, you change the pressure, you change the symptom.
It all comes back to the engineering.
It really does. Thank you so much for sending in these sources and taking this deep dive with us. Until next time, keep questioning the mechanics of how we move.